Hello everyone, I'm Dr. Song from China. I'm coming again. I'm so happy to join this conference online section time. Uh, First, I will share my screen. Moment. Okay. Hello everyone. The title of my presentation is Mini Open Endoscopic Assist ACDF, Mini MOEA ACDF. The UBE endoscopy to assist in uh, 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 completing the classic ACDF procedure. Next, I will use a typical case to introduce the surgical step in detail. In 1953, Dr. Robert Robinson first applied the anterior cervical approach in humans. In 1958, Dr. Ralph Cloud pioneered anterior cervical decompression using a trephine and performed intervertebral fusion with the cycling Draco bone craft. Until today, anterior cervical discectomy, decompression, and fusion (ACDF) is still the gold standard for treating cervical spondylotic myelopathy. I'll share a case. There is a 38-year-old male diagnosed with cervical spondylotic myelopathy, C6-7 cervical dissection. From the pre- and post-operative X-ray, we can only see that our zero P cage was used at C6-7 as a standalone. From the comparison of the pre- and operative axial MRI imaging, we can see that the surgery was very successful. The spinal cord degeneration at 6-7 only indicates a lung disease duration and severe symptom. Here are the preoperative CT and postoperative CT and the 3D reconstruction. The posterior margin of the C6-7 disc space is fully decompressed, showing a trumpet-shaped appearance. That's the end view. The step we enter layer by layer between the carotid sheath and the sternocleidomastoid muscle to reach the anterior surface of the vertebral body. The step is the same as the traditional ACDF approach, except the incision is smaller but still sufficient. Explore the prevertebral fascia and inside it to reach the bone surface. And place the localization needle, confirm the target disc space under fluoroscopy, and then fix the retractor. Insert the angular fibrous with the blade, then use the carotids to remove the nuclear purpose inside the disc. After the disc and the upper and the lower end plates are basically cleared, the direct vision part is completed. Next, we will treat the posterior vertebral margin and endoscopy in a water medium. The water environment provides a clear view of the field of view. We no longer need to look down into the incision, but instead look up the miniature. We use a 4mm high-speed bar to remove the posterior vertebral margin. Hemostasis with radio frequency is easy in the water environment. The posterior longitudinal ligament is very clear visible. Bone wax is applied to the bone surface to stop bleeding and maintain a clear view. And use a sickle knife to open the posterior longitudinal ligament and fully decompress the cervical spine cord. Further clean the lower end plates on both sides. The decompression step is now completed. And now we can remove the UBE endoscope and under direct vision insert the 12 cage. Finally, insert the DLP cage. Of course, a regular cage can also be used. The surgery is completed. Last, this is our published paper. Based on clinical comparative study, MOE ACDF achieves the same clinical outcomes as the traditional ACDF, and our clinical experience suggests that it has certain advantages in complex cases with posterior vertebral osteophytes. Thank you for your attention, dear brother, dear everyone. Thank you.
Thank you, Dr. Song.